Dr. Nadeem, we can start.
Yeah, we can start. Fine. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 15T, which is Erythrocytic Diseases. We are streaming live from St. John's Medical College and Hospital, Bengaluru, Kolkata. We have a very interesting topic, hemolytic diseases of the fetus and the newborn. And to talk on that, we have a very close friend of ours, Dr. Shanthala Devi. She is an MD from PGI Chandigarh, professor and head of the Department of Transfusion Medicine and Immunohematology at St. John's Medical College Hospital, Bengaluru, with areas of interest in hematology, Flowcytometry, transfusion medicine. She is involved in teaching undergraduates and postgraduate medical students and allied health sciences, with multiple publications in various national and international journals. Before I ask Dr. Shanthala to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Shanthala ma'am, please start.
Thank you, Dr. Nadeem.
Yeah, just share your screen, please.
Can you see the screen?
Yes, please.
Yeah.
Please start.
Yeah. Thank you, Dr. Nadeem. Today I shall be talking about hemolytic disease of fetus and newborn. I have tried to make this topic both relevant for both the pathology students as well as the transfusion medicine students. What is hemolytic disease of fetus and newborn? It's otherwise also known as erythroblastosis fetalis, earlier known as erythroblastosis fetalis, and most commonly it used to be due to RH incompatibility. It used to also be known as RH incompatibility. Now all these entities have been put together, and since it affects not only the newborn, also the fetus in utero, the disease has been called as hemolytic disease of fetus and newborn. This occurs due to the destruction of the fetal as well as neonatal red blood cells by antibodies which are produced by the mother. How are these antibodies produced in the mother? Either they are stimulated by the previous pregnancy or by a previous transfusion, and very rarely in the pregnancy itself, certain amount of weekly blood leaks into the maternal circulation in the second and third trimester, resulting in sensitization of the mother and production of the antibodies. So what are the blood group systems which are involved in this disease entity? Most common or the most well known is the RH blood group system, which not only includes the D antigen, the other antigens in the RH blood group system, that is the capital C, small c, capital E and small e, the ABO blood group system, and the other minor blood group systems. So how does this happen? Suppose the mother is negative for the antigen and the fetus carries that particular antigen. When there is a small amount of fetomaternal hemorrhage or a fetomaternal leak, these cells, the cells which are having the antigen, enter the maternal cell and they stimulate the production of an antibody because they are foreign to the mother. This antigen is not present on the mother, and subsequently these antibodies will cross the placenta if they are the IgG type and react with the fetal cells and destroy the fetal cells and cause hemolysis, that is the hemolytic disease of the fetus, and which continues into the after birth as hemolytic disease of the newborn. So in 1939, Levine and Stetson, when they performed a transfusion from a husband's blood to a postpartum woman, it resulted in a transfusion reaction. then they postulated that the mother had been sensitized by the father's antigen, which was present on the fetal cells through fetomaternal hemorrhage, and this antigen was later identified to be the Rh antigen, the most common and the most immunogenic one being the D antigen. Previously, most of these hemolytic disease of newborn was caused, 95% of them were due to the Rh-D antigen, when the Rh negative mother was carrying a Rh positive fetus. This incidence of this disease has steadily decreased since 1968 because of the introduction of the Rh immunoglobulin, Rh, what is in India which is available as Rogam, the Rh IgE, which is given to the mother antepartum as well as postpartum, and this prevents the sensitization of the mother and decreases the incidence of severe Rh incompatibility or the severe hemolytic disease of newborn. Though it is common, the other RBCs incompatibilities have now surpassed the D in frequency at referral centers. The other antigens, which could be because of the minor blood group systems, for example, KEL, the Duffy and the KIT, can also produce the hemolytic disease of newborn. Since the Rh antigen is relatively decreased because of the introduction of anti-D Rh immunoglobulin injections, the other causes of hemolytic disease of newborn have become more prominent. What are the causes of, how does this happen? This happens when there is destruction of the RBCs of the fetus by antibodies produced by the mother. The antibodies which can cross the placenta are only the IgG type. The other classes of antibodies, the IgA, IgM, do not cross the placenta. Most of the IgG antibodies are directed against the bacterial and fungal and viral antigens. So the transfer of IgG from the fetus, from the mother to the fetus is very beneficial, especially in the early neonatal period when the baby's immune system is not yet fully developed. However, this advantage turns into a problem in case where the mother develops antibodies to the antigens which she lacks but carries those antigens. So that is when the hemolytic disease of fetus and newborn occurs. So for this to happen, first and foremost, there should be a leak of the fetal cells into the maternal circulation, that is fetal-maternal hemorrhage. When does this happen? Though this can happen during pregnancy itself in the second and third trimester, the amount of fetal-maternal leak which happens during a normal pregnancy in the second and third trimester is very minimal, and it usually does not stimulate the production of anti-D. The sensitization happens during delivery, or if there is been a spontaneous abortion or an abdominal trauma in pregnancy, an ectopic pregnancy, or invasive obstetrical procedures such as chorionic villus sampling, amniocentesis, cesarean sections, or manual removal of placenta. All this can result in significant fetal-maternal hemorrhage, which can sensitize the mother to the fetal antigens which she lacks. There are various factors which influence antibody response, which are these: the host factors, size of fetal-maternal hemorrhage, the fetal-maternal hemorrhage or leak, parity of the mother, zygosity of the father, immunoglobulin class, antibody specificity, influence of the ABO group. Let us go through each one of them one by one. The host factors. The antibody response depends on complex genetic factors. When in the Rh negative individuals transfused with 200 ml of Rh positive RBCs, only around 85% of them produced anti-D. The remaining people were non-responders and they failed to produce anti-D in spite of repeated exposure to Rh positive blood. Similarly, when Rh mothers, negative mothers who were not administered Rh immunoglobulin were investigated to see how many of them developed anti-D, only 16% of them had developed anti-D. So there are various complex genetic factors which play a role in who develops an anti-D following sensitization with the antigen which is absent in the mother but present in the fetus. The size of fetal-maternal hemorrhage or leak. I already told the fetal cells do cross the placenta during third trimester. This is small and insufficient to produce antibodies, and hence first pregnancy is generally unaffected. At delivery, varying amounts of fetal cells enter the maternal circulation. It ranges from less than 1 ml to greater than 10 ml, and the antibody development occurs within 6 months of delivery. However, some of these mothers, around 7 to 12% of the mothers, develop antibody only after a second stimulus in the subsequent pregnancy. Hence, these Rh antibodies, the hemolytic disease of newborn, have the Rh setting as well as in the minor blood group setting only in the second pregnancy onwards generally, unlike the ABO antibody incompatibility, which I will come to later. The parity. First para I already told, first pregnancy usually escapes without any complications. From second pregnancy onwards, the mothers who develop the antibodies progressively increases. Second para mothers, 1 in 50. If it is parity 5 or more, it becomes 1 in 9. Coming to the immunoglobulin class, I already told you that immunoglobulin IgG is the only one which is transported across the placenta. The transport of IgG begins around in the second trimester and continues till birth. Among the IgG, there are 4 classes of IgG antibodies, IgG1 to G4. The G1, G3 are more efficient in causing hemolysis compared to the IgG2 and G4. What is the antibody specificity which causes the hemolytic disease of newborn? I already told you earlier, hemolytic disease of fetus and newborn used to be known as Rh incompatibility or erythroblastosis fetalis. But as we have progressed and started trying to identify the antibody which is causing this disease, we realized there are various antibodies, not only the antibody to the D antigen. The most common ones which can cause HDFN are anti-D and combination of antibodies like anti-D with anti-C, anti-capital C, anti-D with anti-capital E, the anti-capital C alone, anti-capital E alone, then anti-small c, anti-small e and anti-Kel. The Kel antigens, we have to remember, this is present on the erythroid precursors as well as the mature RBCs. If there is an anti-Kel antibody, that is if the mother is Kel negative and the baby is Kel positive, there is a possibility of the mother developing anti-Kel antibodies. These antibodies will react with the erythroid precursors and cause severe anemia without there being any reticulocyte response or without there being any nucleated red cells. So the hallmark of our hemolytic disease of fetus and newborn, which is erythroblastosis. Because of the hemolysis, there used to be lot of erythroblasts, there are a lot of nucleated red cells in the peripheral blood that may not be seen when the incompatibility is due to Kel antigen. So rarely HDFN occurs due to Duffy, the MNS system as well as the KIT system. The systems in which HDFN does not occur is the Levi's, the I antigen as well as the P. The ABO group. Concomitant ABO and Rh incompatibility between the mother and fetus results in almost a 9-fold reduction in the risk of, that is, if the mother is O and the baby is either A or B. This is an ABO incompatibility between the mother and fetus. If the mother is O negative and baby is A or B positive, there is both ABO as well as fetal, Rh incompatibility. This decreases the severity of the Rh incompatibility because these cells, which when they enter the A or the B cells, as soon as they enter the maternal circulation, they are cleared away by the maternal anti-A and anti-B, and they are removed by the macrophages before the sensitization to the D antigen can occur. So ABO incompatibility along with Rh incompatibility gives a selective advantage and the severity of the hemolytic disease decreases if both the incompatibilities coexist. The zygosity of the father. Suppose the father is heterozygous for the antigen to which the mother lacks. But there is 50% chance that the fetus will be negative for the antigen. And genotyping of the father can help determine the zygosity. Now coming to the pathogenesis. This part I have already explained how we have taken the example of the Rh D antigen. When this fetus is having D antigen and mother is lacking that, this D antigen, when it crosses and reaches the maternal circulation, it results in formation of the anti-D antibodies. These antibodies, the IgG anti-D antibodies, cross the placenta and cause lysis of the fetal cells. This is the pathogenesis of HDFN. Then what happens because of this? Because of the hemolysis of the fetal RBCs, one, there is anemia. This results in congestive cardiac failure, tissue hypoxia and hydrops fetalis or the stillbirth, which happens in untreated cases where there is very high titer of antibodies and the fetus gets affected very early in pregnancy. Then the other consequence of the hemolysis of the fetal cells is the unconjugated bilirubin. This bilirubin is released because of the hemolysis of the red cells. It is unconjugated, and as long as it is in the fetus, the bilirubin is excreted by the maternal liver till birth. But once the baby is born, this results in jaundice because the neonate's liver is deficient in glucuronide transferase, and it is incapable of conjugating all the bilirubin which is produced due to the hemolysis of the fetal cells, and this results in what is known as kernicterus. Hydrops fetalis can occur as early as 18 to 20 weeks gestation. The RBC destruction continues after birth, and I told you this happens due to the IgG antibodies, and as we all know, IgG is not only there intravascularly, it is distributed extravascularly also. So once it is cleared from the intravascular, the extravascular part moves into the intravascular, and its half-life is little longer than the other immunoglobulins. It is around 25 days, and hence hemolysis continues for several days to weeks after delivery. What is kernicterus? In the fetus, bilirubin is cleared by the maternal liver. After birth, the fetal liver has to take over the conjugation of the bilirubin. However, the fetal liver is immature and it is unable to handle this high levels of bilirubin. This results in the indirect bilirubin, which is not water soluble. It is it crosses the blood-brain barrier. One, because normally the bilirubin which is bound to albumin will not cross the blood-brain barrier, but in a newborn the blood-brain barrier is also not completely developed, and it crosses the blood-brain barrier and gets deposited in the basal ganglion, resulting in permanent damage if it is left untreated. So how do we diagnose and manage the HDFN? There is necessity for a close cooperation between the mother, the OB/GYN, the spouse, the lab and the transfusion services which are performing these serological tests. The serological testing of the mother, the type, and we have to do the typing and the antibody screen at the first prenatal visit. Generally this happens in the first trimester. We have to take proper history of previous pregnancies, their outcomes, prior transfusions, and antibody titers need to be done. What do you mean by antibody screening? Screening of the antibodies which are there in the maternal circulation is done by using O group cells. Various panels are available, 2-cell, 3-cell, 4-cell panels, and this is done by indirect Coombs test or indirect antiglobulin test. This has to be done. Generally earlier only the Rh negative mothers used to be tested for ICT, but if we have to detect other antibodies to the minor blood group system, we need to check the Rh positive mothers also. The antibody screening should be done in the first trimester for both Rh negative and Rh positive mothers. This detects not only the anti-D but the antibodies to other antigens in the Rh system as well as the minor blood group systems like KEL, KID and MMS. So when do we do this antibody screening? It is done in the early stage of pregnancy, that is early pregnancy in the first trimester in all the cases. Again, if it is negative, we have to repeat it again in 28th week for the Rh D negative mothers, and in the last trimester, third trimester, again you repeat it in all the cases. A positive antibody screen. If we get a positive antibody screen, that means the mother has an antibody against the O group cells. We need to know what it is. First, we need to take pregnancy history, history of transfusions, prior transfusions, and check what is this antibody directed against. The IgG antibody. Specifically, it is done by doing the antibody identification, and we have to check the father's antigen status also. What is passive immunization? Since now it is a norm to give RH immunoglobulin at 28 weeks gestation, if we do the antibody screen or the ICT in a pregnant mother who has received RH immunoglobulin, her ICT will come positive. It will react weekly in testing and it may remain so for 2 months or longer, but generally this titer will be less than 1 in 4. A titer greater than 1 in 4 generally indicates active immunization. Paternal phenotype and genotype. The father's blood is checked for the presence and zygosity of the corresponding antigen. If the father is heterozygous, then the fetus sample can be taken and checked. If the fetus is negative for the corresponding antigen, then there is no further requirement to investigate the baby. This will help to counsel the patient as well as formulate treatment plans. What is for fetal DNA testing? If the father is heterozygous for the antigen, the fetal DNA testing can be done to check whether the fetus is having or it is lacking the corresponding antigen. Amniocentesis and chorionic villus sampling can be done. Now even fetal cells can be picked up from the maternal circulation itself and can be checked, which avoids the need to do a invasive procedure on the fetus. Now, once the antibody has been identified, we need to see how much of antibody is there. We need to check the antibody titer. So, how do we do this? The same procedure, that is your indirect Holmes test or indirect antiglobulin test, is performed after making a doubling dilution of the maternal serum. So, we do a dilution 1 in 2, 1 in 4, 1 in 8, 1 in 16, so on and so forth till 1 in 2048, it is 2048. If the titer is less than 1 in 16, we need to repeat this antibody titer every 2 to 4 weeks. But in addition, we need to freeze this sample. The first serum sample or plasma sample has to be frozen, and with every next sample we need to run it. When the difference between the frozen sample and the fresh sample is greater than 2 dilutions, it is considered as a significant change in titer. And generally the method by which we do ICT is, for antenatal purpose, is the tube method, because gel method gives higher titers, and this cutoff at which we need to repeat and which is considered as critical has not been yet standardized with gel method. It's preferable always to use the tube method to do the ICT titer, maternal antibody titer. Now once we have done the, we have identified, once we have seen that there is an antibody on screening, we need to identify the antibody. Antibody identification is generally done using 11 cell panel, and the positive red cell antibody screen in negative Rh negative mothers is generally due to anti-D, though a combination of antibodies like anti-D plus anti-capital E, anti-D plus anti-capital C are etc. are known. Positive antibody screening in Rh positive mothers could indicate antibodies to minor blood group antigens, and it is important to know the antibody specificity, as certain antibodies are known to cause more severe HDFN and some are relatively harmless, which I have already told you which can cause HDFN and which never cause HDFN. The maternal antibody titer, if it is greater than 1 in 16, we need to repeat the titers more often. So it is done at around 18 to 20 weeks, and if it continues to be 1 in 32 and above, further investigations for the fetus need to be done. What is the most non-invasive investigation which can be done will be the middle cerebral artery Doppler, which looks at the peak systolic velocity in the middle cerebral artery. What is for RHD? I told you the titer which will be 1 in 16. But for critical titer, if there are other antibodies, for example, TEL, I told you, causes more severe disease at lower titers. A titer of 1 in 8 is as critical, is considered as a critical titer for TEL antibody. The maternal antibody titers, high titers generally indicate severity of fetal disease, but not always necessarily. But however, lower titers reliably predict an unaffected or a mild to moderate fetal disease. The exceptions being the anti-KEL positive fetus, which can cause severe disease. What is this middle cerebral artery? Peak systolic velocity. Here the systolic velocity of the blood which moves in this middle cerebral artery is checked. If there is fetal anemia, reduced viscosity, because of the reduced viscosity, the blood moves faster, and this can be assessed, the fetal anemia can be assessed. This is easy to access, hence this is preferred, and it is non-invasive, no adverse effects to the fetus, and it determines the necessity to do an invasive procedure like photosynthesis. Now, what is photosynthesis? By using high resolution the ultrasound, we can obtain fetal blood samples from the umbilical vein, and this can be used to test for the hemoglobin, hematocrit, bilirubin, blood type. The DCT can be done, the antigen phenotype as well as the genotype can be done of the fetal cells. And what is amniocentesis? It is taking a sample of amniotic fluid, mostly to measure the bilirubin. Earlier, bilirubin is to measure serially over a period of time, and graphs used to be drawn, the Lilly's graph and the Quinan's curve. And this used to estimate the extent of the fetal hemolysis. Now it is not commonly used because of the availability of non-invasive middle cerebral artery peak systolic velocity. Once there is indication of fetal anemia, intervention can be done in form of intrauterine transfusions. Intrauterine transfusions are given when this middle cerebral artery peak systolic velocity indicates anemia, or there is fetal hydrops on the ultrasound. The photosynthesis blood sample shows the hemoglobin is less than 10 grams per deciliter, or if they have amniotic fluid, bilirubin is high. This intrauterine transfusions can be given both intraperitoneally as well as intravascularly. The volume, how much of intraperitoneal transfusion to be given is the gestational age in weeks minus 20 into 10 ml. For intravascular, first the fetoplacental volume is calculated, and later the volume of the intravascular transfusion is calculated. Generally, O negative, leukodepleted, irradiated blood less than 5 days is preferred. It is preferred to given check for the CMV status and as well as the sickle cell status of the blood before intrauterine transfusions are given. It is repeated every 2 to 3 weeks. Where this facility of intrauterine transfusions is not available, premature induction of labor is done after 34 weeks to lower the incidence of stillbirth and to decrease the severity of hemolytic disease in the live newborns. This decision will rest on the analysis of the amniotic fluid, obstetric history, the antibiotic titers as well as fetal ultrasound for maturity. How is the newborn managed? The various treatment modalities. First, there is simple phototherapy, IV immunoglobulin can be administered, exchange transfusion can be done, serological testing of newborn has to be done. So what do we test for in the newborn? The ABO grouping can be done, RH typing, the DCT, the direct antiglobulin test, hemoglobin estimation, cord blood bilirubin, look for the Evidence of hemolysis in the peripheral blood, for example, nucleated RBCs, reticulocyte count can be checked. Phototherapy is a simple procedure by which the unconjugated bilirubin is changed to isomers which are less lipophilic and less toxic to the brain, and generally this will solve most of the problems due to mild to moderate hemolysis. Phototherapy is sufficient. IV immunoglobulin is administered to the neonate. This competes with the mother's antibodies for the Fc receptor on the macrophages of the infant spleen and thereby decreasing the hemolysis. Exchange transfusion. This is done in severe cases of hemolytic disease of newborn. This is to remove the high levels of bilirubin to prevent chronic stress. It also removes the circulating maternal antibodies. It removes the sensitized RBCs and it replaces the infant RBCs with RBCs without the corresponding antigen. What is the criteria for exchange transfusion? So there are two ways of looking at it. At birth, look at the cord blood and the bilirubin, and after birth, look at the baby's hemoglobin and the serum bilirubin. The cord blood hemoglobin greater than 14 grams, the baby can be observed. When it is between 12 to 14 grams, you consider doing an exchange, and when it decreases below 12 grams and it continues to fall further within the first 24 hours, it is necessary to do an exchange transfusion. Similarly, the bilirubin in the cord blood at birth will be low because the maternal circulation has been taking care of the bilirubin. So it will be like around 4 milligrams per deciliter, less than 4 milligrams, observe the baby, 4 to 5, consider an exchange, and greater than 5, do the exchange. After birth, the hemoglobin greater than 12 grams, observe the child, less than 12, consider an exchange, and if it continues to fall within the next 24 hours, do the exchange transfusion. Serum bilirubin after birth less than 18 milligrams per deciliter, observe the baby, between 18 to 20, consider an exchange transfusion, and if it rises to 20 milligrams within the first 48 hours, do an exchange transfusion. I will not go into the details of exchange transfusion. The blood which is to be transfused generally will be negative blood, negative for the antigen for which the mother has developed an antibody. For example, if we are talking about Rh, antibody, we will transfuse negative blood and the mother's blood group or the common blood group. For example, if mother is O negative and baby is A positive or B positive, the baby will be given O negative blood. If the mother is A negative and baby is A negative, then you can give the common group, that is A negative or O negative can be given. So generally O negative blood can be given which is less than 5 days old to do the exchange transfusion. How do we prevent the occurrence of HDFN due to anti-D? The event which changed the course of HDFN due to anti-D was when they discovered that administration of Rh immunoglobulin could decrease the sensitization of the mother. How does this act? It binds to the D antigen on the fetal RBCs in the maternal circulation and prevents sensitization. However, this is a simple explanation. This does not explain how the amount of Rh immunoglobulin which is given to the mother is around 300 micrograms and or little more than that. But how will this small amount of immunoglobulin bind to all the fetal red cells and clear them off and preventing the immunization of the mother to the D antigen does not explain, this alone does not explain how the sensitization of the mother is avoided. So there is perhaps other mechanism like prevention of B cell priming which will make the anti-D, it interferes with the B cell priming which will make the anti-D, and this is how it acts. So what are the indications to administer Rh immunoglobulin? Antenatally, at 28 weeks of gestation, Rh immunoglobulin is given in mothers who are negative in ICT. The ICT negative mothers receive antenatal Rh immunoglobulin at 28 weeks gestation. If there has been an abortion, ectopic pregnancy or any external invasive procedures like amniocentesis, chorionic villus sampling, any abdominal trauma during pregnancy, or accidental or inadvertent transfusion with Rh positive blood, and within 72 hours after delivery of Rh positive baby, you need to give Rh immunoglobulin. And also, if we have any doubt, like for suppose we have a weak B antigen, we are not sure whether it is necessary to give anti-D, because it is little controversial whether to give anti-D in weak D when weak D is detected, especially when we don't know genotype to see whether it's a weak D or a partial D. It is preferable to give it's preferable to err on the side of giving the Rh immunoglobulin in these situations, especially when you have a very weak ICT positive, you are not sure whether the ICT is positive. Wherever you are unsure, it is preferable to administer the Rh immunoglobulin. How do you calculate the dose? For that, we need to estimate the fetomaternal hemorrhage. Generally, in day-to-day practice, a standard dose of 300 micrograms is given. However, there are certain which takes care of around 30 ml of fetal maternal hemorrhage into the maternal circulation. However, there are instances where there is a higher fetomaternal hemorrhage, and then you may need to give a higher dose. So tests which are done are like rosette test, where these fetal cells which are there in the maternal circulation, if you add anti-D and add indicator cells, they form rosettes. So you can detect fetomaternal leaks of greater than 10 ml by this method. Then you have the acid elution test or the Kleihauer Betke test, also known as the KB test, which can be done to actually estimate the amount of fetomaternal hemorrhage. These RBC fetal cells contain HbF, the fetal hemoglobin, and they can be detected by Flowcytometry also. So the dose of Rh immunoglobulin to be given if around 300 microgram. It is enough to neutralize up to 30 ml of fetal blood loss. How do we do this acid elution test? The acid elution test is dependent on the principle that the fetal hemoglobin which is there in the neonate or the fetal cells is resistant to acid elution. So based on this principle, a smear is made and it is subjected to a mild acid. If it is all adult hemoglobin, the hemoglobin elutes, and after staining with eosin, it looks like ghost cells. On the other hand, if it is only fetal cells, it will all take up, the hemoglobin does not elute, it remains inside the RBCs, and when you add eosin, stain it with eosin, it will appear pink in color. So we can use this to calculate the volume of fetomaternal hemorrhage, the number of fetal cells into the maternal blood volume divided by the number of maternal cells, and this should be divided by 30 and add 1 to give the number of vials to be administered in cases of higher fetomaternal hemorrhage, more than when you suspect the hemorrhage is more than 30 ml. So this is how a Kleihauer Betke test looks. This is the normal adult sample showing mainly the ghost cells. These are the WBCs which are taken up. This is the HbF resistant, the pink cells are the HbF which is resistant to the acid elution, and it is stained with the eosin. Now coming to the very common hemolytic cause for hemolytic disease of fetus and newborn, that is the ABO blood group incompatibility. This occurs, statistically it can occur 1 in 5 pregnancies if the mother is O, baby is A or B. However, this does not result in severe or even moderate kind of hemolysis, and generally doesn't get picked up, and though it is more common, it is less severe, and this is because the ABO antigens are poorly developed at birth. Normally the ABO blood group system antibodies are all IgM type of antibodies. However, in O group individuals, small amount of IgG antibodies also are present. The anti-A, anti-B which are there in the O group individuals, small amount of IgG, anti-A and anti-B can be present, and these can cross the placenta and bind to the fetal cells which may be A or B and cause hemolysis. However, this is not so common, not so severe, though it is more common because the ABO antigens are poorly developed at birth. Though there is antibody, because the antigen is not well developed, the lysis of the RBCs will not take place. So, how do you differentiate between ABO and RH, hemolytic disease of fetus and newborn? Generally ABO, because these are preformed antibodies. ABO antibodies are naturally occurring antibodies and most of them are complete antibodies, the IgM type. However, small amounts of IgG incomplete antibodies can be seen in O group individuals, and these can technically cross the placenta and cause fetal hemolysis if the baby is either A or B. So this can happen in the first pregnancy. However, with RH and other minor blood group system HDFN, this is rare. And can the disease be predicted by the titers? In ABO, no, we cannot predict it by titers. However, in RH, yes, we can predict it by titers. What is the antibody which is seen in ABO? It is the anti-A and anti-B. In RH, it is the anti-D, or if it is some other minor group antigen, those antibodies can be present. Bilirubin is normal at birth and anemia is generally not present. However, in RH incompatibility, bilirubin can be elevated and they can be anemic. And how do you treat these babies? Generally, if at all, if ABO incompatibility causes some amount of hemolysis, it can be treated with phototherapy, and extremely rare cases will require exchange transfusion. In RH incompatibility, phototherapy is common, exchange transfusion required, and intrauterine transfusions are never required for ABO incompatibility, but for RH incompatibility, intrauterine transfusions are sometimes required. The peripheral blood also varies between ABO and RH incompatibility. RH incompatibility is to be known as erythroblastosis fetalis. Because of the fetal anemia, the fetal nucleated red cells start getting released because of the hemolysis, and there are a lot of NRBCs and there is polychromasia at birth. The number of NRBCs exceeds the WBCs, and very often if you see the cell counter things, it will be in lakhs sometimes, and there will be around 500 to 600 NRBCs per 100 WBC if you look at RH incompatibility. However, in ABO incompatibility, because it's a milder form and the hemolysis is happening gradually and very in a limited fashion, the only evidence of hemolysis is presence of spherocytes. When you see a lot of spherocytes in the peripheral blood, don't always jump to the conclusion of hereditary spherocytosis. It could also be, especially if it's a neonate, it could be a ABO incompatibility. So this is how we differentiate between ABO and RH incompatibility. So with this, I would like to end my talk. And what are these advances which have happened, which have been shown the progress in this disease? Is first when the RH Ig immunoglobulin administration was started, then use of ultrasound to look at the fetus to see whether there is hydrops, the Doppler assessment of middle cerebral artery peak velocity, the ability to take fetal blood sample from the cord using high resolution ultrasound. Now you can also look at the fetal cells in the amniotic fluid, look at the genotype, look at the fetal DNA analysis in the maternal plasma, as well as doing intravascular intrauterine transfusions. These have enabled many of these babies which would have otherwise not been able to survive, which would have resulted in stillbirth, to be delivered with a good hemoglobin and with less evidence of hemolysis. So these are the advances which have happened over a period of years. References. Thank you.
Thank you, Dr. Shanthala. Wonderful presentation, very crisp and very clear as usual. There are some questions.
Yes.
You can see them on the chat box. I can request Dr. Ashwarya, she can unmute and directly ask questions.
Yes, Dr. Ashwarya.
Pregnant, ma'am?
Yeah.
Can you hear me?
Yeah, I can hear you right now.
Ma'am, I'm getting cases of antibody, but they have got antibody previously 3 years back for the previous pregnancy as a passive immunization.
Yes.
So now, will the ICT will be positive or negative? It should come as positive or negative, ma'am.
Usually the passive immunization lasts up to 2 months, not more than that. So 3 years, definitely the passive immunization will not last that long. The half-life of your any IgG antibody is 25 days. So 3 years is unlikely to be because of, if it is positive, your ICT is positive, it's unlikely because of the anti-D which has been administered previously. It is most likely that she has got sensitized.
Then I should consider it as active immunization, right?
Yes, active immunization, yes.
Okay. So is it not like it doesn't depend on the titer, 1:4, 1:8?
Yeah, that is, yes, titer is also important. The thing is, if it has happened in the, suppose we have given anti-D in 28 weeks of gestation and you do at around 32 weeks, and if you get a titer of 1:4, more likely that it is because of the anti-D which has been administered. But this is 3 years back, so unlikely it is because of the passive immunization, more likely to be active immunization.
Yes, yes. Okay, ma'am. Thank you.
Thank you, Dr. Ishwar.
Dr. Aravind has a question. You can also unmute and ask Dr. Aravind directly.
Thank you, sir. No, my question, I got a part of my question I got answered, that in which conditions exchange transfusion may not be beneficial. That ABO I saw in the last ABO incompatibility. Any other, madam, in your experience, if it is where it's not beneficial?
Exchange transfusion is more when we are looking at the hemoglobin levels as well as the bilirubin. It is done just to remove the excess bilirubin. So it is not the question of not beneficial, it is the question of when do you decide to do an exchange transfusion. Suppose the hemoglobin is low and the bilirubin is raising, to prevent this bilirubin from getting deposited in the brain and causing permanent neurological damage, we need to remove this bilirubin. And the easiest and fastest method would be to take it out by exchanging the blood. Take out the blood and replace it with blood. And this acts in 4 folds. One, it removes the bilirubin. It removes the sensitized RBCs which would have got lysed in the glucose. So that also is prevented. And circulating antibodies also are removed, as well as you are removing the cells. Even if there is some amount, even when we exchange, some amount of antibody which was there in the extravascular compartment will move into the intravascular compartment even after the exchange. That will not get a cell to bind to, because you have replaced the fetal cell, baby cell with the cell which does not carry the antigen. So in this way, it is beneficial. So we decide by that based on 2 things, the anemia as well as the.
Thank you. Thank you.
Thank you, Doctor.
Anybody else would like to ask any question to Dr. Shanthala? You can unmute and ask directly any question.
Hello, ma'am.
Hello.
This is about primary mother with triplet pregnancy following IVF. One baby fetal reduction was done, and the babies were born. The other 2 babies were born preterm.
Okay.
And ICT was positive in mother.
Okay.
DCT was negative in both babies, but both babies are having high retic count.
Okay.
So, what could be the condition?
Bilirubin?
Initial bilirubin is normal.
Okay.
Prophylactic phototherapy, babies are kept under prophylactic phototherapy.
Yeah.
So, in which condition can this occur, ma'am?
Because you are telling bilirubin is normal, only how was the delivery? Was it normal delivery, or if there is fetal hypoxia during delivery also, that can also raise your reticulocyte count. Any hypoxia will push the.
Yes, it's the normal forced delivery, the first baby.
So how long did this
second baby spontaneous?
Did it
There was
last?
some amount of depression at birth.
Sorry?
There was some amount of depression at birth.
Okay.
Perinatal depression.
Okay. So maybe that is because for the retic response rather than it being because of the antibody. What antibody was this? This was RH itself, is it?
T2 reduction was done.
No, you said
One
ICT
baby T2
positive.
reduction was done.
ICT positive, you said, no? So was it
In mother, yeah.
as anti-D or was the mother RH negative?
Yeah, mother is RH negative.
RH negative. Okay. And titers were done?
No, ma'am.
Okay. So most likely this is not due to the hemolysis is not happening. It's more due to hypoxia during delivery, and because there's no increase in bilirubin itself, so there is unlikely to be that there being hemolysis.
Okay. So probably because of the hypoxia, the retic has gone up.
Because
Okay, ma'am. Thank you.
Thank you, Doctor.
Anybody else would like to ask any question? Right. So I think there are no questions. So Dr. Shanthala, thank you so much for this wonderful presentation. We will request you to share the PDF of this so that we can upload it on the Google Drive which we have, where we are sharing all the PDF of presentations.
Sure. I will do that, Dr.
And this will also be available on the YouTube for convenient viewing in the future. Thank you so much, everybody, for joining in. Thank you, Dr. Shanthala. Take care. Bye-bye.
Thank you, Dr. Nadeem. Thank you for doing this program, and thanks all of you for joining in. Thank you.
Thank you. Bye. Good night. Bye.
Discovery.